right, everyone. Thank you. That was excellent, informative. I learned a lot. We have a few minutes for questions. Are there any questions for the panel? Dr. Ferdinand is back? Okay, good. I'll start. Dr. Ferdinand, could you speak a little bit about the practice that you have of the reminder text regarding blood pressure?
Text my BP NOLA. It was a sponsored small trial. In general, what's being recommended now is that we try to get valid devices for our patients. That's what the validatebp.org website is.
Okay.
Because patients often have blood pressure in the clinic, in the home setting, it could be normal. Or in some rare cases, it could be normal in the clinic and outside the clinic be elevated. So out-of-office blood pressure, not only from the 2017 guideline, but the United States Preventative Task Force, it's a class 1 approach. And it makes sense because if the patients measure their blood pressures and you're able to communicate either by texting or by telehealth, it's better than just waiting for 2 or 3 times a year for a condition that's omnipresent. I mean, people live with their blood pressure 24/7.
Yeah, okay, I like that idea. Anybody else with questions?
We have a question online.
Okay.
This one's also for Dr. Ferdinand. Is there any health significance or difference in response to therapy related to the ethnicities of study samples in China compared to in the US and other places?
Well, in general, there's a movement away from saying which drug for which person based on race, ethnicity. And indeed, the Chinese studies may be criticized because it's not a heterogeneous population as we have here in the United States or in Brooklyn. But at the same time, it's pretty convincing that lower is better, that the 140/90 is not good regardless of race, ethnicity, that we should target lower blood pressures. Now, the idea that, for instance, Black patients use a diuretic or calcium channel blocker versus an ACE inhibitor or an angiotensin receptor blocker, we really think that the main thing is to recognize these patients are going to need 2 or more medicines. So now the push is not for which medicine based on race, ethnicity, but a combination of medicines for all patients. There is a study from West Africa called CREO, in which they used a combination of an ACE inhibitor and calcium blocker in the West African population. They did excellent in terms of blood pressure control. So I think the take-home message is medicines aren't bad. I think the United States population is making a big mistake with this move away from science and medicine. Lifestyle modifications, of course, needed. Too much salt, not enough potassium, too much obesity, physical inactivity. But that it will be a combination of medicines, often 2 medicines in 1 pill to control blood pressure in these difficult to treat populations.
Thank you. Another question?
Hi, I'm Dr. Pardo. Yeah, just curious, just out of curiosity. Are you hearing me clearly now? Yeah. Just out of curiosity, I was wondering if the increased gynecological risks that seem to be evident on a global level, whether that affects women employability in the workplace, and does that have any implications for their economic well-being and that of their families?
Thank you. That's really a great question. So a lot of the, when they look at the global burden of disease and the impact of disability, from the economic standpoint, that's where a lot of that burden comes from, and the economic impact, on a society. So, lost days, at work, not just at work, in school age, related to menstrual hygiene. So, lost girls missing days from school, and depending on the country and the structure, says what type of support is there or protections for women. So that's not just gynecologic, it even goes to pregnancy, and it relates and parental leave as well. So, unfortunately, sometimes employers may say, there's a higher chance that this individual is going to take a maternity leave, and then what the impact is on their business. So from the gynecologic perspective, the financial and economic burden is not just the direct costs, but the costs related to employment. So missed days, the functionality, the being able to function at work, and also even at the school age, the missing school. And there have been, at least at the school level, school-based interventions to address menstrual inequities at the school level, where when they had interventions to increase access to menstrual products and reduce the stigma, that school attendance increased, at least in those particular countries.
Okay. Another question? Am I loud enough? I can hear you, but I'm not sure if everybody in the back can. Can you? Okay, thank you.
Hi, I wondered for both doctors, is there an increase in family sharing history? All right, because my experience is that sometimes you find this running in families, the fibroids, all of the different things that you've described. Are families increasing their discussion from generation to generation?
Good question.
And most of the work that I do is in prolapse, and there also is a huge component of oh, sorry. Well, I guess you could hear me anyhow. No, but I think that's a really great place where if there was somebody who had some initiative to make that, more widespread, that would be fantastic.
I certainly think it's a place to start for women. And with all of the things we've talked about today, this whole issue of families discussing things that appear to run in families.
Yeah. And I think that's really interesting with gynecologic care and the, matriarchal lineages and the way that we talk to our, daughters and mothers and grandmothers. Because a lot of these things do run in families, but a lot of times they're also kept secret. And it's not passed down because of, well, at least in the world of prolapse, shame, and the world of incontinence, there's a shame associated with it, and people are shy to talk about it. But I think that, we need to get over that so we can pass on the wisdom and pass on what we know.
This is such an important topic and question. I think it goes to that stigma. It's never talked about, and I think it's just kind of in women you just deal with. It's a part of life. You struggle through it, you suffer through it, and therefore you don't talk about it, and so you feel your experiences are your own. I remember when I was doing residency, I was so surprised, like my grandmother had a hysterectomy, and it was all these things, and her sisters and aunts, and nobody talks about it. It's just kind of one of those things, and oftentimes they don't know why, they had hysterectomy or certain, conditions. So I think we are getting to a place where we are more open about it. And it's because of like the advocacy and the things, happening. And now we're talking about gynecologic conditions and we're studying gynecologic conditions, and we're realizing, it's not just something we have to suffer, that actually has impacts on our life, on our health, on, our livelihoods, and, and everything like that. So I hope it's real, that that aspect of not talking about it, but I think we are starting to talk about it more.
I have one last question. Is there anybody else with a question? Oh. Angela, is there one in the chat? Nope. Oh, come.
Hi, to the panel. Excellent presentation and very informative. And Dr. Porter, you mentioned Jamaican-born women in terms of health outcomes. Did it make any difference as to when the person came to the United States, whether as a child or adult or older?
That particular study didn't go into that detail, and even to find any study that digs into it that deep was hard to find. And I think now that we are understanding more about the intersectionality and subgroups, that more people are doing more studies like that. I know from the maternal health aspect, we've been doing, trying to understand that differentiation, how long they've been within the country, and having certain outcomes. I don't know if anybody's actively doing that, at least within gynecology, but certainly that is the next step to be able to go deeper. Now we know that there is this disparity. Is there a difference based on, just as you said, how long they've been in the country and, and other, socioeconomic factors?
Thank you.
Okay, one last question. Want to give folks 10-minute break before the next session?
Okay. And my question is regarding high blood pressure. A lot of time we got patient with elevated systolic blood pressure, and sometimes we have patient with diastolic elevated. But we have a lot of controversy. People said in terms of risk factor for stroke or cardiovascular disease, in your experience, doctor, is there any differences? Like if I have elevated diastolic blood pressure, I have more risk for cardiovascular disease or for stroke, or if I have systolic, is there any differences in terms of risk factor for these diseases?
So most of the studies that I showed you, the SPRINT trial, which was the large US trial, the Chinese trials, looked at systolic. That's because once you get past middle ages, 55 into the 60s, 70s, the systolic goes up, the diastolic goes down. So diastolic is a risk factor in younger persons, but age in itself is a powerful predictor of disease. So for most of the big studies now, we're looking mainly at systolic. The idea that if you lower the systolic, you'll lower the diastolic too much doesn't really seem to be a problem, because the systolic, where the pulse pushes the blood, and then the diastolic runs off very quickly, and you have a low diastolic, they call it a pulse pressure. That seems to be the main predictor of risk. And that's regardless of where you are in the world. We talked about recent immigrants from other countries. It appears that people who come to the United States and they lose some of their connectiveness to prepared foods from their home often do worse when they start eating some of the American foods, the Southern diet, the foods high in sodium. So, quick answer to your question, mainly systolic in older persons, middle age and older, diastolic younger persons, but because age is such a powerful predictor, the studies really look at systolic.
Thank you all for an excellent panel. Appreciate you. And we'll take a 10-minute break and then start again.
All right, thank you.